Patient is a 3-year-old girl with extremely tender abdomen and fever. Patient has not passed stool for the last 2 days. Abdominal pain for over a month, but it has increased in intensity for the last 1 day. Fever 1 day. On ultrasound, we found a large midline septated cyst with echoes. It is in the lower abdomen and the upper pelvis. It measures 7x8x4 cm. There is no solid component in it. Overall septa are thin and complete. No invasion to surrounding structures. Mass effect is noted on small gut loops. Mild mass effect is noted on the dome of the U-bladder. Lesion looks like in the lower portion of the small gut mesentery. There is no fat or fat fluid level in it. No calcification. No hemorrhage. Gut loops are not dilated. Channels and both kidneys are normal. No para-aortic lymphadenopathy seen. What could be this lesion? What would be differential? How to proceed to conclusion? The described lesion in a 3-year-old girl with fever, acute worsening of abdominal pain, and constipation, along with a large midline septated cystic lesion in the lower abdomen and upper pelvis, raises concerns for several differential diagnoses. Possible differential diagnoses: infected mesenteric cyst, most likely given fever, tenderness, and location. Mesenteric cysts are rare, benign intra-abdominal cysts that arise from the mesentery. Septations, internal echoes, and mass effect are common. Infection/inflammation can cause tenderness and fever. Omental or mesenteric lymphangioma can present as large, thin-walled, septated cystic masses. Typically non-tender, but if infected or hemorrhagic, can cause pain, fever. Duplication cyst, enteric or colonic, often located in the small bowel mesentery. Septations, internal echoes, due to secretions. May cause obstruction, volvulus, or infection. Abscess, infected cystic lesion. If the cyst is truly infected, it could represent an intra-abdominal abscess, secondary to a perforated duplication cyst or infected mesenteric cyst. However, the absence of surrounding inflammation makes this less likely. Ovarian cyst, unlikely due to midline location. While large ovarian cysts in young children can occur, this lesion appears to be more in the mesentery rather than adnexa. Hydrometrocolpo, less likely, typically seen in imperforate hymen or vaginal atresia. More midline and posterior, pushing the bladder upward. The 3 main differentials for this large, septated, cystic lesion in the lower abdominal mesentery are: 1. Mesenteric cyst, most likely. Key features: large, thin-walled, septated cyst. Can cause mass effect on gut loops. May become infected. Rightward arrow. Fever, tenderness. Next steps: 4 antibiotics if infected. Surgical excision is definitive treatment. Aspiration alone has high recurrence. 2. Enteric, duplication, cyst. Key features: often closely related to bowel, small intestine. Secretions. Rightward arrow. Internal echoes seen on ultrasound. Can lead to obstruction, infection, or hemorrhage. Next steps: surgical excision is needed if symptomatic. May require bowel resection if intimately attached. 3. Omental/mesenteric lymphangioma. Key features: multiloculated cystic mass, often large. Usually not tender unless infected or hemorrhagic. Contains chylous or serous fluid, no fat/calcifications. Next steps: if asymptomatic, observe with ultrasound. If large or symptomatic, surgical excision. Less likely differential diagnoses: abscess. Rightward arrow. Unlikely due to lack of clear signs of pus or inflammation. Ovarian cyst. Rightward arrow. Unlikely due to midline mesenteric location. Hydrometrocolpo. Rightward arrow. Unlikely, as bladder is not significantly displaced.